How doctors test for malaria. This is what we are going to discuss today. I am Professor Teke Apalata, a specialist in clinical microbiology. So we will discuss malaria testing and what is it that doctors do to make the diagnosis of malaria. So that's why we are going to respond to the question, how doctors test for malaria. Now, before that we respond to the question, how doctors test for malaria, let's first try to understand the malaria transmission and what the malaria parasite does to our body. Then we will come back to the test. So in order to develop malaria, that is a parasitic infection, we need two things. First, we need the malaria parasite that we call Plasmodium, and we need a vector, that is a mosquito. So that mosquito will carry the Plasmodium, that is the malaria parasite, then it will come to bite a human host. But that mosquito is just not any type of mosquito. It's a mosquito that we call Anopheles, and not just any Anopheles, it must be a female Anopheles. So the female Anopheles will carry the malaria parasite that we call Plasmodium, especially at the stage of sporozoid. It will carry it, then it will come and bite a human host. Then following that, the malaria parasite will then progress into the liver of the host. So the first infection that will take place will be a liver infection. Then following the liver infection, the parasite will then go into the bloodstream. And from the bloodstream, it will then infect the red blood cells to create a blood infection. Then it will rupture some of the infected red blood cells will be ruptured. The patient will also develop what we call hemolytic anemia. Then if you are living in a malaria endemic area where those mosquitoes are around, another mosquito will then be able to come and bite you and take in your blood that contains the parasite. And when the mosquito will go to bite another person, it will then transmit the infection and the chain of infection will continue. Now, if it happened that our initial human host would develop the initial infection, was pregnant, was a female who is pregnant, the malaria parasite is also able to be transferred to the baby. You know, that's what we call in utero transmission. So that's why malaria is responsible of killing many children, especially when the women are still, their mother are still pregnant, those babies can have in utero infection, or many other children die, you know, after birth. And there is a high mortality rate with malaria, especially among the children below the age of 5 years. So this is how the malaria transmission takes place. So we have an infection in the liver. Then from the infection of the liver, we then have the infection in the blood. Now, because of that, one of the important symptoms is fever. So the patient will then develop fever because of the parasite in the blood. The patient will develop fever and chills, a general feeling of discomfort or malaise. Then the patient will have headache, muscle or joint pain, and fatigue. So if we are dealing with children, usually children develop nausea and vomiting, diarrhea, and abdominal pain. But most of the critical sign is fever. And that fever is what we call an intermittent fever. And an intermittent fever has specific characteristics that you need to know to suspect, especially if you associate that with a travel history in an endemic area of malaria. with the presence of intermittent fever, you can be able to think of malaria among your list of differential diagnoses. So intermittent fever is a type of a pattern of fever in which there is an interval where the temperature is elevated for several hours. That's what we call a paroxysm of a fever. It's achieved the paroxysm of a fever, followed by an interval where the temperature drops back to normal, that we call remission of the fever. So you can see here, there is an interval on the last graph. You can see on day one, following the incubation period, then you have an increase of the temperature. So this will be there, the fever will be there for several hours, for a number of hours. It will stay there. Then that's what we call paroxysm of fever. So you have that sudden increase, then you have that, it will reach its peak. Then after that, there will be a period of remission. So the temperature will come back. Then at the normal level. So this is on the temperature chart, this is the normal temperature, this horizontal line, that is the normal. So the temperature will really come back to the normal. Then the patient will stay without fever for a couple of hours, like in this case, 72 hours, if you are infected with Plasmodium malaria. So if you are infected with Plasmodium malaria, you will have a remission for 72 hours. So after that, on the 4th day, then you have another peak. You have another peak. Then after that, there is a remission again, and so on. So if you are infected with a Plasmodium malaria, the fever peak will be coming every 72 hours. You have another peak. That's what we call quatern malaria or quatern fever, quatern malaria. Then if you are infected by Plasmodium vivax or Plasmodium ovale, this remission period will take 48 hours. That's what we call tertiary malaria. Tertiary malaria. So you have a peak, then 48 hours remission, then you have another peak. Okay, so that is tertiary. But the quatern, you have a peak, 72 hours later, you have another peak. So this, it gives you an idea of the species that is causing malaria. But the most dangerous of those Plasmodium is what we call Plasmodium falciparum. Plasmodium falciparum will give you a picture, an intermittent fever pattern that might be irregular. Sometimes it looks like the fever is continuous. You see here, you have an increase in the temperature. You reach the plateau, then it looks like the fever remains there. It's a bit continuous, until the 2nd day. Then you will experience a remission around the 3rd day. Then you have another peak, okay? Then it remains there again. So sometimes it looks like quotidian, or it looks like a tertiary, or it looks irregular in terms of pattern. So you have an intermittent fever, but it's in pattern. But it's irregular, the pattern is irregular. But for tertiary malaria, you will see an increase on 1st day. Later on that day, there is a remission. Then 48 hours, you have another increase. So you have similar pattern that repeats itself. So if you see that, and you link this with the patient travel history, you suspect malaria in this patient. Now, when we come to the question of how doctors test for malaria, there are broadly 2 categories of tests that are commonly done. We have all other tests that can be done, but it's mainly done in the research setting. But in the diagnostic setting, there are broadly 2 categories of tests. There is what we call thick and thin blood smear for malaria. So that is a microscopy test. It's a rapid test, but microscopic rapid test. And the microscopic rapid test that we call Rapid Diagnostic Test for malaria. So we will then discuss those two categories of tests. So what is the thick and thin blood smear? So what happens is that we will see how you will do the collection of specimen. Then you have your microscopic slide. You put a drop of blood on it. But then what will happen is that one will be a thick smear. We will discuss that. But another one will be a thin smear, where the layer of the film, will be thin. Now, the difference between the thick and the thin is that the thin smear, it will help you to know the morphology of the parasite in order to determine the species. But the thick smear will just be able to tell you, if there are parasites in, although you will not be able to appropriately determine the morphology of the parasite and identify the species. But the value of the thick smear is that you have many red blood cells in one place, so that if the patient especially had a low level of parasite in the blood, you can still be able to identify them. So the thin smear help you to identify the morphology and the species, but the thick smear will give you an opportunity to be able to see if there is a parasite somewhere, because you have an opportunity to bring in a large number of red blood cells together and try to identify if there is any red blood cells that is infected. But before we go to the smear microscopy, let's look how the blood sample collection is done. You can do blood sample collection in two ways. You can do the finger prick, so take blood here from the finger prick, that is the capillary blood, or you can use the venous blood, okay? But if you collect the venous blood, you need to ensure that you use a EDTA tube, so you collect the venous blood through a vacuum tube containing an anticoagulant, preferably the tube that contains an anticoagulant called EDTA. Okay, so that's what you see here, an EDTA tube. If you are not doing the test on site with this, you can send it in the lab, then it will be processed there. But you can make your smear also on site. So you can do a finger prick here, but make sure that you use always 70% alcohol to clean the area to avoid contamination and so on, or maybe to transmit the infection to the patient. And you do then the puncture of the finger. But in children, especially the infants, we can also puncture the heel, okay? But make sure that when the blood comes out here from the finger or from the heel, make sure that you wipe away the first drop of the blood with a clean gauze. Then you collect the second one. You can then bring your slide, a clean slide, to touch the blood, okay? Or you can use a micropipette to collect a bit of the blood and put a drop on the slide to make your smear. So that's how you do it now. How do we make a thin blood smear? Now you can see here that you need two clean slides, okay? So this is one slide with a drop of blood there. Then you bring the second slide, you place it there next to the drop, okay? And you can hold that slide at a 45-degree angle toward the drop of the blood on the specimen. You see, you hold it there. Then here you allow the blood to spread along the entire width of the slide, of the spreader slide, okay? Then after that, you can see that while holding the spreader slide at the same angle, you still keep holding it at the same angle. You push it, forward. You push it forward. You see you were here. Then you push it slowly. You push it forward, rapidly but smoothly. So you push it forward to make a very thin smear. Okay, so that's how you make a thin smear. But how you make a thick smear is that you place your drop of blood, then you use the second clean slide, but you use the corner of the second slide and you spread the drop of the blood in a circle, just to achieve the size of 1 to 2 centimeters of diameter, so you spread it around. Now here you can see the difference between the thin smear and the thick smear. And it's advised that you make at least 2 slides of thin smear and 2 slides of a thick smear, just to try to increase the sensitivity, to try to increase the sensitivity of the test. So that's how you make the thin and the thick smear. Then after that, those slides will then be stained. And the stain that we use is called Giemsa stain. So we use a Giemsa stain. So Giemsa stain, the name Giemsa is from a German chemist. It's a test that is named after a German chemist. His name was Giemsa, for his application of a combination of reagent, to try to demonstrate the presence of the parasite, the presence of the parasite in the blood. So he mixed up a number of reagents. Then those reagents, if you put them in contact with your smear, then they will then color differently the blood cells, and you will also be able to identify the parasite. So that's why the test was named after him. So this Giemsa stain is a gold standard staining technique that is used both whether you are testing for thin smear or thick smear. So it is a gold standard test. Now, what is the principle of the Giemsa test? So I say that the Giemsa stain is a differential stain. It is a differential stain because it's able to differentiate different components of the blood composition, including also the parasite, to show the presence of the parasite. That's why it's called a differential stain. It is made up of a combination of reagents, 3 main reagents. You have the azo, you have the methylene blue, and you have the eosin dye. So those 3. Now those 3 have different affinities with different parts, elements in the cells. Remember, the cell, like your blood cell or any cell, that you find in the peripheral blood, has a cytoplasmic membrane, it has a nucleus, and it has many other substances inside the cells in the cytoplasmic area. So the azo and the methylene blue are basic dye. So because they are basic, they are able to bind to the acid nucleus to give a blue-purple color. But the eosin is an acidic dye, then it is attracted by the cytoplasm and all cytoplasmic granules that are there, which are alkaline. So when they bind there, they produce a red-orange color, okay? So those dyes are also able to morphologically differentiate the nuclei with the cytoplasm of erythrocytes and also of other cells like leukocytes, platelets, and they are able to show the presence of the parasite. Okay, so the fact that Graham managed to put all these reagents together, and if you use them, you can be able to see different cells on this slide. Now, what is the staining procedure? First, the staining procedure of the thin film stain is different from if you are staining the thick film. Okay, so there are differences. Now, when you are using the thin, thin smear slide, so what you do is that on a clean, dry microscopic glass slide, you already make a thin film of the specimen. So after making that, you leave it to dry. Okay, then you dip the smear, you do about 2 to 3 dips into pure methanol. So you use methanol to fix the smear. So this is one of the difference, because we don't use methanol to fix the thick smear, but we use methanol to fix the thin, the thin smear. So you use methanol to fix, and you leave it to air dry for 30 seconds. After dipping it in the pure methanol, then you leave it to dry you leave that slide to dry for 30 seconds. Then you float the slide with a 5% Giemsa stain solution for 20 to 30 minutes. You leave it there, then you flush with tap water and you leave it to dry. So that's how you stain your thin film. So what do you see? Now, this is an example of a slide that you can see. Now, all these are red blood cells. What you can see here are red blood cells. But in arrow A, so this is the arrow A, you can see here, it's showing you a classic ring-shaped of trophozoid of Plasmodium falciparum. You can see here, so this is what we call a ring, so you have a classic ring shape. But here you can see here, this gives you a classic headphone. It looks like a headphone, shaped trophozoid of Plasmodium falciparum. That's what you can see here. This one, it's a ring. This one is a classic headphone. And here you can see one thing that is also particular about Plasmodium falciparum is that you can see multiple trophozoid ring inside one cell. So the first thing is that you will see the size of the infected red blood cells did not change. So the cells did not increase in terms of size, or the shape did not change. They look the same like the red blood cells that are uninfected, okay? But those that are infected, so the first thing you look, the red blood cells, the size are the same between the infected and uninfected. Then you look the typical ring shape of Plasmodium falciparum. You can see either the classic ring or the headphone that you can see here, with those two there, dots there, Or then the other thing that confirmed that it's Plasmodium falciparum, you might see multiple rings inside one cell. Like here we see 2 rings in one cell. So it gives you a great idea of the morphology of the cell. Then you can report that this patient is infected with Plasmodium falciparum trophozoid. Okay, now, so this is what you see when you are infected with when a patient is infected with Plasmodium falciparum. We say the characteristic of the ring, especially the early characteristic of the ring. So we have said that the first thing, morphology of the red blood cells and the shape, there is no change when you compare the infected and uninfected cell. Then you look for the characteristic trophozoid. But here, the other thing you can look here, this is the schizont, okay? You can see here the schizont stage. And those are what we call the gametocyte, But how is different from Plasmodium vivax? From Plasmodium vivax, you can see these red blood cells that is infected. there is a modification in its size and shape. So the size and the shape here changes, okay? The shape changes and the size increase of the cell. The cell, the infected cell become enlarged. And then you have the trophozoid that is here. This trophozoid ring, if you compare with the one I showed you for Plasmodium falciparum, this one has what we call an amoeboid shape. It has an amoeboid shape. Now for Plasmodium malariae, the cells will remain also unchanged in terms of size and shape, but the trophozoid ring that you can see here has what we call a band shape. It has a band shape. And here you have the schizonts. You can see the schizonts here are different in terms of number from the schizonts here. Here you can see plenty of them in the Plasmodium falciparum. Now in Plasmodium, if it's the patient is infected with Plasmodium ovale, you will see the change in the size and the shape of the cells become oval. You have oval. You can see the cell here have an oval shape. You see, the infected cells become oval. Okay, so when you see that, you can suspect Plasmodium ovale. So that's how you look. Now, let's look some questions, some exercises. Question 1. This is the slide. Try to think about it and make the diagnosis. Okay, so the first thing you look the shape of the cell and their size. So you can see here, those are uninfected cells. You will see that the uninfected cells and the infected cells all have the same size, almost similar size, similar shape, okay? So then you can also see the typical ring, okay? And in some places you see the headphone, and other places you see the ring, and you can see multiple ring, you know, infected one cells. So this, you make the diagnosis of Plasmodium falciparum. Okay, so this is a ring stage of Plasmodium falciparum. Okay, so you have a multiplicity of rings within the red blood cells. Now let's look another case. Look at this smear, malaria smear slide, and make the diagnosis. Now here again, you start with the shape of the cell. Those are an infected cell, and you look those that are infected. The size and the shape look also the same. And you see here multiple ring here, typical ring for Plasmodium falciparum. But then here in the middle here, you can see there is a schizont. Okay, so it's not just, the disease, it's not just at a ring stage, but it reaches here, you can see the schizont. Okay, so the answer is that it's a thin film showing Plasmodium falciparum ring stage and schizont in the center of the slide. Let's look at this one. Okay, so what do you see here? You can see that this is the infected cell, and these infected cells, you know, its shape and the size is different from the uninfected. You can see it's different. So it's a schizont. You can see that it's a schizont of a Plasmodium ovale. So you can see the shape is the oval shape of the infected cell. It's oval, it's enlarged, it's irregular, and it's not the ring stage, but it's actually the schizont stage of this. But one other thing you can do, especially in a patient who are infected with Plasmodium falciparum, is that you need to calculate the density of the parasite. Remember, this Plasmodium falciparum is a serious infection. So you have to know the density of the parasite, how many cells are infected, how serious, how severe the condition might be in terms of laboratory workup. So you need to determine the percentage of parasitemia. You know, it's essential. So the number of infected red cells, the way we do it, you count the number of infected red cells, not the number of parasites, but the number of infected red cells. So you look at in 1,000 red blood cells. So when you look at the slide, you count 1,000 red blood cells, and out of 1,000 red blood cells, how many red blood cells are infected? So you make on the proportion. So you take the number of red blood cells that are infected, divide by the total number of red blood cells, you can count up to 1,000. So let's say that you counted 30 infected cells out of 1,000 cells, then it gives you a percentage of 3%. That is the density of the percentage of parasitemia, how many cells are infected. Okay. In cases of severe form of malaria, especially caused by Plasmodium falciparum, you will see that the density will be extremely high. Now, that was the thin smear. Now, in terms of thick smear, the staining procedure is different. So you add the thick smear of blood. When you make the thick smear of blood, the way I say, 1 to 2 centimeters in diameter, and you air dry it for 1 hour. Okay, so you air dry it in 1 hour. You can put it in a standing rack for 1 hour. Okay, it's not like the thin smear where we use methanol to fix it, but here you air dry it for 1 hour. Then you dip the blood smear into a diluted Giemsa stain. Remember that the previous one we used 5% Giemsa stain, but here you dilute that Giemsa stain again. So you prepare that by taking 1 ml of the stock solution plus 49 ml of phosphate buffer or distilled water to make a dilution. Then you can you dip your thick smear into a diluted Giemsa stain. Then you wash the smear by dipping in a buffered water or distilled water for 3 to 5 minutes. Then you leave it to dry. Then you are ready now to do the reading. You know, so here you can see how the thick smear slide looks like. Okay, so you can see here you have red blood cells, you know, and you have some few infected cells here. So the only thing you can see is that those 2 cells are infected. This one infected, this is infected, this one also is infected, but you are not able to describe the morphology. But what it allows you to see is that you have many of red blood cells in one place, you know, because the smear was thick, so it brought many layers of red blood cells, and you can be able to quickly pick up if there is any red blood cells that is infected. But you are not really able to describe appropriately the morphology of the parasite to be able to say whether it's Plasmodium falciparum or Vivax or Valley or malaria. But here you can see, you know, quite a number of red blood cells that are infected here. Then you can also measure the density of the parasite using the thick blood smear. Now, here the counting is different. We use the plus system while you are dealing with a thick blood smear. That's why you can say malaria 1 plus, 2 plus, 3 plus, you know, 4 plus, you know. So 1 plus is only when you have, you know, so you try to count the number of parasites by microscopic field. You can also do the counting differently, but this is the commonest way to count, you know, when you have 1 to 10 per 100 tick field, or that's malaria 1 plus. 2 plus is when you have 11 to 100 parasite per 100, you know, field, microscopic field. 3 plus is then 1 to 10 parasite per microscopic field in one microscopic field, and 4 plus is when you have more than 10, you know, parasite per microscopic field. Okay, so it gives you an idea, but this method is less precise, you know, if you compare with the density counting method we're using the thin smear approach. So that is the microscopy testing. You can do it with thin or thick smear. And the other test that doctors request is what we call a rapid diagnostic test for malaria. The rapid diagnostic test for malaria use the principle of immunochromatography. So the immunochromatography relies on the migration of a liquid across the surface of a nitrocellulose membrane. So most of those tests, rapid diagnostic tests that you can order or you can do on bedside or in your office, doctor's office, because they are like a dipstick, you know, test, you know. So those immunochromatographic tests are based on the capture of the parasite antigen. So on the strip, there is malaria antibody, a monoclonal antibody, whether it's antibody for Plasmodium falciparum or any other Plasmodium. So you need to know, because some of the tests only test for one species, others test various type of species. So you must know which test you are using, because sometimes if it becomes negative, it does not necessarily rule out malaria, but it just, the test maybe was testing for Plasmodium falciparum, but the patient is infected with a Plasmodium ovale or vivax, then you can miss it. Okay, so then the antibody is on the strip, then it's going to capture the antigen. It's going to capture the antigen. Okay, then it will progress, but there is a second or a third capture of monoclonal antibody. So we will see like here. So what happened here is that you have the strip. It's a nitrocellulose strip. Then in this strip here, you have a place where you will put your drop of blood. Then you have a lysing agent that you will add here. It will then allow this to progress. So this is the buffer that you add, okay? This is the buffer that you add. But already when you put here, the lysing agent, there is what we call a labeled antibody, or so this is a labeled antibody. This free labeled antibody will already try to move here with the antigen. Then when you add the buffer allows the blood to progress on that nitrocellulose strip, okay, to try to see where the test, what we call the bound antibody is. Because from here, then the parasite antigen will be captured by the labeled antibody. So you have two antibodies here. You have the labeled antibody and the bound antibody. The labeled antibody is a free antibody. It is a free antibody that will capture the antigen first, and then progress with here. After adding the buffer, it progresses. Then you have then another specific antibody, like let's say for Plasmodium falciparum, that is a monoclonal antibody, that is a bound antibody, that will then bound to that specific antigen. Then when that happens, it gives you a change on the color. You will see the line that will appear here. So you have two lines, one for the test and the other one for the control. Okay, so the control, you check the control. If the control works, then you check if the test is positive or negative. But what are the antigens that those antibodies are directed against? So the number of antigens that are valid, that are used, the first one is the HRP2. So the HRP2 is a water-soluble protein that is mainly found in a Plasmodium falciparum. Okay, it is expressed on the red blood cells membrane surface, and it's the HRP. There are 3 types of HRP. There is a 1, 2, and 3, but the 2 is what is abundant in almost all red blood cells membrane surface of infected red blood cells by Plasmodium falciparum. That's why this antigen is validated to be used on the strip to make the test. But the other antigen that are also used are the PLDH and aldolase. Those are enzymes, that we can find in a different species of Plasmodium, So if you see the antigen is only the HRP2, mainly that test is only looking for the presence of Plasmodium falciparum. But then the other species, they can be there. Probably they use the PLDH or aldolase, that are enzyme that you can find. So this is how the kit looks like, the malaria antigen. So you can see here, this is the B, it's the hole for the blood. That's where you put the drop of the blood. Then, this is the B for the buffer. And also you have this small bottle, it has the buffer. But before you add the buffer, you put the specimen here. S is the specimen. That's where you put the drop of your blood specimen. Then you add a drop of the buffer. So from here, it will migrate, found this. Then you have a labeled antibody that binds with it. Then it progresses, okay? Then here you will see the test, whether it's a Plasmodium falciparum or Vivax or any other Plasmodium, that the test, and here you have the C, it's the control. Okay, so you check first the control, then you read your test. Okay, so this is what you have here. S hole, it's where you add the blood. You have a drop of blood here, then you add drop of buffer. Okay, then it then progresses. Okay, so let's see here. So that's what I explained. Okay, so you put the sample, you put the buffer, it progresses. Then here you have the falciparum antibody test that is there. If the antigen is in the blood, then this antibody will bind to it. Or you have also other antigen for other Plasmodium can be there. Then you have your control test. Now, this is, if you look at this, this test, you check first this band, that is the control. You can see that the control is positive. The control is there, so it means that the test worked. But these 2 lines are negative. It means that this test is negative. So it's only the control that appears. The antigens for the Plasmodium species are negative. So you report this test as negative. But here, if you see this, you check the control is working, then you check this bond here, it's there. So it's positive, but it's not Plasmodium falciparum, it's other species of Plasmodium. And for the Plasmodium falciparum, you see that it's negative. So it's malaria that can be caused by other species, okay, that are non-falciparum. But here you can see that your control worked. This test here for other species is positive. For Plasmodium falciparum is also positive. So this is a mixed infection, with different species of Plasmodium. But this test here is invalid. Why we call it invalid? Although the test here is positive, but because your control did not work, you cannot consider this. You have to repeat the test and you report this one as invalid. So you can also see here, you put your specimen here, you put the buffer, then it progresses. You have test 1, test 2, they are all negative. It's only the control that worked. So you report this as a negative. But this one, you can see the initial test worked, it's positive. The second one is negative, the control is positive. So this is a malaria positive. Now, this T1 can be either Plasmodium falciparum, and the T2 is other species. So this is how you make the diagnosis of malaria. So responding to our initial question, how doctors test for malaria, now you understood that you can either request for a thin or thick smear, doing a Giemsa staining technique, or you can also do a rapid test. Now, when the rapid test is done, if the test was done in the lab and the result is sent to you, you need to know whether they tested only for one species, because some lab, they only have the strip for testing for Plasmodium falciparum. And they will say result is negative because they did not find it. But you need to assure that they tested also for other species. Is the rapid test testing for all different species, or it's only tested for one species? Thank you very much. Goodbye.